Welcome everybody, and thanks for joining our session on the future of the NHS. And for the sharp-eyed amongst you, you might be thinking, who's this guy, because he's not on the screen. Let me tell you, my name's Mark Essex. In my day job, I'm a management consultant, and I'm always telling clients they need to be more agile. And I'm getting some of my own medicine today because Ben asked me to step in 75 minutes ago because I was supposed to be in one of your seats asking the questions, and now I'm going to be on this seat asking Paul the questions. Dr. Paul Goldsmith is the one member of our panel who hasn't been pinged today in this pandemic, and he is going to share his insights on the future of the NHS. Thankfully, Stephen Smith and Dr. Chaand Nagpaul have also sent contributions, so you don't have to miss what they've got to say, and they've done it through the magic of digital, which we're all getting used to in our lives at the moment. So you're in the right place if you're here for the future of the NHS. What that does mean is we have the opportunity to make this session really, really interactive, and I hope you do. There's a microphone here for a reason, and so when we've heard from Dr. Chaand and from Stephen Smith and a little bit from Paul, what we'd really like is for you to come and tell us what you think, what your questions are, and challenge Paul and others about the future of the NHS. So that's our session. But I'm going to start by hearing the voice of the doctors with a video from Dr. Chaand, Chairman of the British Medical Association's Council. Run VT. Always wanted to say that.
Hello, my name is Dr. Chaand Nagpaul. I am Chair of the British Medical Association Council. The BMA represents about 160,000 medical students and doctors across the UK. So we have a really good understanding of the experiences of the medical profession. I'm also a GP. I've been a GP for about 30 years, so very much also understand the perspective of looking after patients. Now, what would I change on the basis of the experience of the pandemic? Well, I think I'd say that the first thing is we need an NHS that has a proper infrastructure of enough people, enough staff, enough beds, enough facilities in the community, and a proper public health infrastructure. We actually entered the pandemic with a woefully inadequate numbers of doctors. We had about 10,000 unfilled vacancies and about 80,000 staff that had not been, vacancies that hadn't been filled. We also entered the pandemic with about a third of the hospital beds of countries like France, and only about a quarter of the intensive care beds of a nation like Germany. Public health itself had been defunded over many, many years, budget cuts for around 400 million. We certainly did not enter the pandemic with an adequate infrastructure. We also at the time had record waits for cancer treatments and hospital treatments back in sort of January of 2020. And so when the virus took hold, we were already under pressure. And one of the first things the NHS had to do was to repurpose its hospital beds to become effectively critical care facilities and intensive care beds. And that's why for several months we had an NHS that was effectively a national COVID service. If you go back to the months of March, April, May of 2020, we had to stop almost all non-COVID services in hospitals because we needed to create that capacity. Now, we also built, of course, Nightingale hospitals to create more capacity, but then the difficulty we had was that because we didn't have enough doctors and nurses, they couldn't be in two places at once, so they couldn't actually staff those other facilities, which meant that many of the Nightingale hospitals were underutilized. So the lack of staff really did impact quite significantly. You know, many of the doctors that I represent, like an ENT surgeons or gastrointestinal surgeons, had to learn new skills to become critical care doctors, helping out in COVID wards and facilities, because we just didn't have enough doctors to do that sort of work. So there's no doubt in my mind that if we had the numbers of doctors that is taken for granted in other nations. As I said, about 3 times as many in many of the comparator nations we would want to compare ourselves with. We would have been able to, I believe, do both the COVID work in the first wave and some non-COVID work at the same time. And what that meant was that around 20 million fewer patients were seen last year in outpatient clinics. And as you know, about 2 million patients didn't have operations, and we're now facing a backlog of about 5.1 million patients, which is an absolute record for the NHS. The second thing is public health. As I said, the funding of public health as a whole has drastically been cut in recent years. And what we found was that in a pandemic, what you need are teams of experts who can contact trace, who can give advice, who can process tests, and we just didn't have the capacity. So as a result, again, if you cast your minds back to those months, people were waiting sometimes a week or 2 for their coronavirus test result. And it was also very difficult to have tests. In fact, for some of the time in March, you may remember that people like myself, doctors, could not even be tested in the community. The tests were restricted for hospital doctors only, or staff, and even those in care homes couldn't be tested. But what we then ended up doing was outsourcing the whole testing to private services, and this was done, at very short notice, and it wasn't really successful. When you then look at how effective the private services were, they were actually picking up or contact tracing about 60% of people, whereas the local teams of public health experts, these are doctors, public health nurses and other specialists who are trained for this job, were really picking up about 90% of patients in contact tracing so that they could be isolated. And so, I think there's a lot of lessons to be learned here, that we must develop an NHS that has, for a start, the equivalent numbers of doctors to other Western nations, that has the equivalent numbers of hospital beds, that has the equivalent levels of diagnostic services. We're way down the list when you look at the numbers of MRI scanners and CT scanners we have compared to other nations. I think we're literally, third from bottom in Europe. That also has enough GPs, and you'll all be familiar of the difficulties GPs have been having recently in coping with demand. That has enough facilities in the community so that people who are ill in hospital but don't need to be in hospital as they're recovering can come out and be looked after and cared for in the community, and has ultimately a public health service that is owned by the state, that is actually serving the nation by experts who understand the public's health as part of a whole system, not a piecemeal approach, which is what we've seen with test and trace and laboratory testing that is not part of the NHS. So I think all of those things do need to be addressed as a major learning experience for our health service. And now is the time to do it as we face another crisis of sorts, a crisis of a backlog, which is probably going to take maybe 5 years plus to clear. But we can certainly do that more effectively if we're honest that you simply can't run a health service without the people, tools and facilities to deliver on the needs of the nation.
Well, lots to absorb there. And I think Dr. Chaand touches on lots of the questions facing us as we come out of the pandemic. We've all become much more aware of health, public health in particular. And Dr. Chaand says there's lots of lessons to be learned, Paul. We need more doctors, more beds, more diagnostic facilities, more GPs, more public health, more community facilities. We want all of that joined up, and now is the time to do it. I'm joined by Dr. Paul Goldsmith, who is a neurologist, practicing neurologist, also on the Big Tent Advisory Board, president of Closed Loop Medicine, so he does work in the private sector on precision treatments. So you know a thing or two about the NHS. What do you make of what Dr. Chaand said?
Well, I broadly agree with everything he said. The question is how to make a difference, because he could have said that 20 years ago. In fact, those things were said 20 years ago, and various things tried, and we need to understand what was tried and why it didn't work, and why is it going to be any difference this time. So 2002, There was the Wanless report, so the Labour government, Tony Blair's first time in office, commissioned this report onto the future of the NHS, and Wanless said, unless we urgently address public health, the NHS will collapse. And it wasn't addressed, and instead we've just put more and more money into it. And if I think back to when I first qualified 30 years ago, the NHS budget was 25 billion, and it's now 150 billion for England. And okay, we've got inflation to take account of, but if I was given 75 billion every year then to improve the well-being, the lives of the patients in front of me, absolutely I would have put money into more scanners and more nurses and doctors, but I would also put a lot into the determinants of health, around the economics, the early years, parenting, housing, and that has been neglected, and it's not been joined up. And so the bigger picture, I think, is that there's a financing and incentives challenge and a coordination challenge. A patient I saw recently referred with epilepsy in his 20s. Now, he was born to a mother who was an alcoholic, that took drugs. So at birth, his brain was already, had taken a hit. He'd been dealt a tough set of cards. And then is growing up in a dysfunctional family. He's not learning the social skills, the psychological skills to navigate out of trouble in a bad area. So gets in a fight when he's older, brain damage, hence the epilepsy, needing extra NHS care and lifelong social care from the local authority. Now, how do we get upstream and stop that happening? Because the returns of investment, and the biggest investment is in those early years, take a long, long time to play out. And they involve multiple actors, yet the optic is all NHS. And there are some other really interesting things which are happening which might provide some of the answer. We heard, Charlie Craddock, some of the really exciting advances in genetics. Another child I think back to when I was called as a junior who was dying from a muscle disease, and the kid did die, spinal muscular atrophy, fatal condition. Now curable by genetic therapy, absolutely amazing. Single infusion. The problem is it costs over $2 million for a single infusion. How on earth are you going to pay for that? Well, we buy houses and we mortgage them, we pay over a very long time. Another breakthrough just very recently, the first disease-modifying therapy for Alzheimer's been licensed in the US called aducanumab. Amazing, because a big dementia crisis. Problem, $55,000 a year. And it's not quite clear how well it works. So what you can maybe do is you can effectively mortgage it and then pay if it really works. But what about addressing hypertension and all of the other factors for dementia? Maybe that's making the difference. So you need to think about integrated data sets and different ways of rewarding the whatever you're doing to the patient. So I think actually, standing back, we need to be much more innovative in terms of addressing the determinants of health and rewarding local authorities, a bit like what George was saying, I think, last time. We know it's not just the NHS bill, the local authority bill, it's the policing bill, it's the how much taxes are being paid. What is the potential gap? And then incentivize, and you need the integrated data set. So people are saying, no, don't share data. Well, we do need to share data in the right way if we're going to address these problems. And it's not just about more hospitals and scanners.
So I take that, and I think prevention rather than cure makes lots of sense. I definitely understand finance and incentives. That's my world, and I buy into your logic. I wonder, right now, with an elective backlog that's going to take 5 years, millions of people needing hips and knees, do we think we're going to engage with that when people are really going to be talking about waiting lists and writing to their MPs, and that might be the subject of the next election? To give us a perspective on this, we've got another contribution from someone from the acute sector, Professor Stephen Smith, former chair of East Kent Hospital Trust, and he's given us his take. Let's play Stephen.
Well, good afternoon. I'm Stephen Smith, and I do apologise most profusely for not being with you this afternoon, but I am quarantining, which is rather topical, I suppose, and I've been asked just to say a few words about my thoughts about the future of the NHS that I very much regret missing because of the quarantine. There is by any measure no doubt in the country that our much loved health service has performed almost miracles over the last 18 months and has demonstrated, if we needed any demonstration, that we have one of the most accessible and, in times of crisis, one of the most extraordinary healthcare systems in the world. However, if you think about it and look more closely, there is no doubt that we have some of the most outstanding and world-class doctors, nurses, and health managers compared to any system in the world. Unfortunately, when you look at the performance of the National Health Service, not just in the times of coronavirus, but outside of that time, our outcome measures in cancer, cardiovascular disease, dementia, is actually rather poor. We usually score, I don't know, maybe 25th best in the world, 28th, 29th. And frankly, for a health service which has such outstanding people, it's either that those outstanding people are not quite as outstanding, which I don't believe, or there is something wrong with the system. And I strongly believe that the system which we introduced 80 years ago, the bones of the system are the same as when Nye Bevan introduced them 70 plus years ago. Why would we assume that this structure of delivering medicine would be effective in the 21st century? And the problem is that we have an over-centralized system which in the times of crisis can deal with a single problem. And we know full well that yes, we have been able to deal with the single problem of coronavirus, but we now have 7 million people on our waiting lists. We simply didn't have a system which had the resilience to be able to handle the pandemic. Casting aside the arguments about whether the committee led by the previous Secretary of State should have provided the country with greater provision, even so, every winter we have a crisis in the health service. And we have a crisis in the health service, not just because of a lack of funding, but because of the way in which we fund, and more importantly, the way in which we run the health service. Now, we're all committed to the new concept of integration of care, with an integration between social and health care. But let's not, before we get into that argument, not forget the fundamental point that Michael Marmot has been making for over 15 years, which is that health outcomes are determined by economics, probably more than almost anything else. And whilst we might want to integrate health and social care, we should not overlook the fundamental basic problem of our healthcare system, which is the inequality in our society and the inequality of economic opportunity and well-being. And we should not be detracted into simply thinking this can be resolved by yet another reorganization of the health service. Not that a reorganization of the health service is not urgently needed, but we need a reorganization of our economic service such that we can reduce inequality, which in itself will be the biggest driver of transforming healthcare. But let's just look at the health service itself. Why is it that such outstanding research that we have in Britain through the life sciences, such outstanding clinicians, respected throughout the world, and I've lived and worked all over the world, there is no question that the quality of the British medicine and British nursing, fully appreciating that it's undertaken by many people who are not British, let's remember, but the quality of our system is extremely high. What is not respected throughout the world is our system. Why do you think no other country is falling over backwards to introduce the National Health Service system? Is it because our erstwhile friends on the continent are incapable of running a socialised healthcare system? I don't think so. Is it because our colleagues and friends in Australia and Canada are not able to run a decent healthcare system with outcomes, all of which are superior to our own? No, it's because of the centralisation of our system does not allow us to deliver a modern healthcare system. And there is a fundamental here. The fundamental is that healthcare is not a car factory. It is not a widget producing factory. And we approach it with the concept of a centralised widget producing factory. GPs seeing patients in 8 minutes. What sort of measure is that of the need of care? Some patients only need a couple of seconds to say, "Thank you very much, doctor, I'm reassured." Others need a really complicated discussion of why they are depressed or they are unhappy or whatever the reason is. The concept of the 8-minute GP consultation tells you everything, absolutely everything. It's about throughput and not what it should be, which is outcome. It doesn't matter whether 20 people seeing a GP in the morning have all been seen within 8 minutes. It does matter that 90% of the people, whatever length of time they had with the GP, are actually satisfied and have been dealt with appropriately. So we need to change the whole concept of how we do health and recognize that that's how countries with better outcomes approach it. And that's because they appreciate that it is a professionalized service. It's a professional service industry delivered to you not by managers, but by professionals called doctors, nurses, pharmacists, scientists, the whole panoply of the professional people who come together to deliver you healthcare. And what we have tried to do in Britain is to industrialize this process, which is not what patients want. Patients, I'm one myself actually, recently having had major heart surgery. And I have to say, the service and importantly, the individual professionalism of every single person, from the cleaner to the person who checked up on the cleaner, not to put it mildly, to the outstanding surgeon and the surgical team who did my heart surgery. But it was their professionalism. And they approached it not that I was a widget, but that I was a patient who needed, in this case, very specialized services. But it was conducted within a system in which I, the patient, came first. And secondly, the environment in which they could deliver the service was pretty well dictated to by them and not somebody in Whitehall or some civil servant behind a desk, which is certainly not the way to run healthcare. So we have a fantastic opportunity with our National Health Service, but we need to wake up early and quickly and realize that we do have the means to have an outstanding system, but unless we transform the health service fundamentally into a professional service which genuinely serves the needs of patients, we will not make any further changes. Yet another centralized, top-down driven health service system will drive the professions into a substantial state of disrespect. And is it not surprising that here we are for the first time in over 40 years with the consultants at least threatening industrial action and nurses being offered a 1% pay rise after everything they have done? That is disgraceful. There is nothing less to call it than disgraceful. But it reflects this failure to understand that we need a professionally driven service, not funded immeasurably out of some wonderful magical pot, but a service which can genuinely deal with the ability to provide professional services to the patients within, of course, a legitimate financial envelope.
Gosh, well, there's a lot to unpick there. I'm going to ask Paul 2 or 3 questions off the back of that. But as I say, what I'd really like to do is hear from you. So if you've got a question, get yourself ready to step up and pitch it, and we'll get Paul's take as a clinician. We could all violently agree about how we need more resources. I want to ask some questions, Paul, I'm afraid, that might expose some tension. So Stephen talked about inequality in society. I heard from a former GP the other day that said there's an app available which you can take a picture of your rash and it will give you a pretty good sense of whether you need to go and see a dermatologist because it might be a problem. And when I say pretty good, better than a lateral flow test. And when I thought that sounds like a great idea, we have just improved the productivity of treating people with these conditions, the response I got back was, but the same old people who are digitally included and will jump the queue and get themselves sent straight to the dermatologist without going to the GP. And that's a problem because that exposes more health inequality. And I'm thinking, well, which do we want? Do we want to treat more people faster or more people equally? What do you think?
Yeah, I mean, this has sort of been an argument over many years that if one area makes some innovation, then it's going to lead to unfairness, and so we don't get any innovation or spread of innovation at all. But really, as that sort of epilepsy case I told you about illustrates, by far the biggest lottery is not whether you have access to a particular bit of tech, it's who your parents were and where you were brought up. I mean, that's by far the biggest determinant of your life chances. But from the tech side, I mean, one thing that we can do is sort of loosen control on clinicians and start to delegate more. So with that device, why not give it to the practice nurse or the auxiliary, and they can use it if the patient doesn't have the tech themselves, and they can do the triage. You could provide a sort of a faster access for people who don't have access to the tech, just to balance the waiting list. So I think there are ways in which, because we do want fairness. Fairness is really, really important. It's a basic sort of human drive, but that should not be a blocker to introducing new tech.
So that's quite interesting. If I go back to it, that makes me think about another point Professor Stephen made about the 8-minute appointment, how some people need 2 seconds, some people need much longer. And do you think we would live with a situation in which perhaps the GP knows or has a pretty good sense of which patients need 2 seconds and which patients need 20 minutes and starts to segment their market? I come from the private sector, this is how I think about these things, and start to say, look, you're a frequent flyer patient, you get this. You're someone who I know you've got a long-term condition, you know how it works. Maybe I give you more trust to refer yourself. Is that ever going to work?
Well, it's sort of happening already, and change has been forced on the system because of the likes of Push Doctor and the like, where they are providing these online doctor services and essentially siphoning off all of the young, healthy people. And so other GP surgeries are becoming enriched for the older with the chronic morbidities who are needing a lot more time. And so there's going to need to be some adjustment in payment flows to reflect patient complexity. Again, it comes back to data to allow this equilibration. Otherwise, it's going to get really unfair. There is that difficulty, I think, in my practice, that if you get a couple of patients who take an hour and then you're going to be penalised in terms of your patient interaction scores because the next one is having to wait a long time. So I think we can get much more sophisticated.
Thank you. Do we have anybody want to pose a question? Step on up.
So I just saw some news on BBC News and the Financial Times that we are facing a Nhs Labor Shortage. And also at the same time, the government says that NHS staff doesn't have to quarantine after they have close contact with someone who has a symptoms. So what do you guys think of the labor shortage problem, and what would be the future?
Yes, I think it's going to get worse. Unfortunately for Mr. Javid, in terms of the waiting lists, and one of the reasons is because of labour shortages. The labour planning has been difficult and at times terrible. I mean, I think back to 15, 20 years ago, Charlie, when we started, doctors were mainly male, and then there's been a gradual shift to females. They did their projections of how many new medical students, assuming a male population, and not females who might want to go off and get pregnant and then come back part-time. So that's one of the reasons now why have a shortage. But the other thing which is happening, see with COVID, it's making people reflect on their lives and actually if they want to work full-time anymore. So I think there's going to be a lot of people who drop their hours and retire early, and it's going to get worse before it gets better. There needs to be more freedom in numbers which are recruited and trained up by local hospitals. There needs to be more flexibility in the types of roles and the delegation, and this is where tech can come in, that say, okay, you're allowed to prescribe this range of drugs for this condition within this particular range, and then outside of that range, then refer up to an expert. We're going to have to be more flexible if we're going to meet demands.
Thanks, Paul. Next.
So I've just got an observation first off, that one of the things that really seems to be the case is that the biggest barrier to improving the NHS is actually the attitudes of the general population, the general public. So 3 quick examples. Every time anybody threatens to close a local hospital, there's a campaign. Actually keeping small local hospitals open kills people. We have general practitioners where the expectation of the public is that they are the repository of the entirety of all medical knowledge from the moment they leave medical school until they retire, and yet of course we should actually just have much better trained diagnosticians rather than necessarily people who are trying to be the Google in their brains. When we ask people what they want from the NHS, in the top 3 replies, every major survey that's done, there is more local control and an end to the postcode lottery, which are mutually exclusive requests of the NHS. So how do we bring the general population along to reforming an NHS that is now right up there above every other institution in the country as untouchable, when we all know it shouldn't be the NHS as we think of it today? Yeah, completely. It's sort of being more honest in terms of the trade-offs, having those meaningful conversations and debates, because usually when there's patient involvement, the plan has already been concocted, and then you have the patient involvement basically to sign it off, and so it's not proper co-production. But the political side is interesting. I've been involved in clinical senates for years and years, and it's the same thing over and over again around, as you say, the local hospital does not have the critical mass to serve the particular area safely, and so needs to be closed for safety reasons. But then patients march and their MPs will leave their seat. I think part of the answer, again, comes from tech, and it's separating structure in buildings from function and who supplies and works within those buildings. So you can start to get the sort of specialist units beamed in, if you like, to the local hospital and the local badge. So I think that's part of the answer. And similarly, that sort of more fluid dialogue between the local generalist and the specialist. And some of that could be automated in terms of the algorithms. And I see a big change happening. And we generally, with technology, we overestimate sort of how soon it's going to happen, and then underestimate the impact. All of the big tech firms saw healthcare $1 trillion to sort of revolutionize it. They came in and it was realized, God, this is really complicated, so step back. And are now doing it in a more measured way. So I think over the next 5 or so years, we will see quite a transformation.
Sorry, yes.
Thank you. Disclosure here, I work for NHS England. And I've been around hospitals for the last 14 years, and I do improvement. So I work with clinical and operational teams to help them improve what they do. Sorry, I'm quite nervous standing here. But before that, to spice things up even more, I was in the car industry for 18 years. Okay, so there's a lot of good stuff in here, but I think it's a provocation, and I am provoked. It presents itself as an either-or, either management-led or professional services-led, and I think it's and. It's a combination of the two, working hand in hand. Delivery in the NHS is the product of clinicians and managers working together when it works at its best. I'll give you a little example. I'm currently working with consultant pathologists down in Derriford Hospital in Plymouth to help them improve their turnaround times, right? So real production environment, it really is. But they are highly skilled, highly trained, artisan, crafts people within a production environment. So that's why it's two things working together. Because every single day, on average, there's 106 cases coming in through the door as specimens for them to work on. So that's a production environment. And you have to link that with their skills and make it work together. So it's not either or. So welcome some comments on that.
So I don't think that was the one I wrote, as a disclaimer. I think one of the problems with medicine is that it's too interesting. And so you've got really, really talented, bright people and doctors, and they just stay at the front line and they don't want to go into management. So completely agree, you need that mix. You need those insights from the coalface.
So I think that's really interesting. We've got two questions come up on the slider, and they sort of link to Tim's question from earlier as well about public attitudes. So how do we convince prevention rather than just firefighting? And as I say, brave person who wants to slow down on the waiting list backlog to invest in some prevention right now. And then if health services are necessarily rationed, how do we give local people a say in which services and treatments are required? And underneath both of those, there's a question about bravery. In fact, it's there at the top, isn't it? When are we going to, what would it take, do you think, to have a conversation which we have realistic, honest discussion that we can't do everything, $2 million per patient, or we need to pay for it in a very different way? Yeah. Is COVID a situation that's going to provoke that discussion?
I suspect not. I'm also quite pessimistic just because I know we've said this for decades and nothing's changed, so I suspect we'll just muddle on. But no, there's hope. Who will take over from Simon Stevens, and what will Sajid Javid do? So I don't think they will be motivated to make any change, and we've had health and wellbeing boards linking local authorities and NHS, and it hasn't worked. There needs to be the incentive. So I completely agree with what George said in the earlier session. It's around, I think the innovation is data and financing to provide those long-term rewards on what does the shift in the envelope of spend over 5, 10, 15, 20 years. That's, I think, the answer to the top one. And Sajid Javid used to be in the Treasury, so maybe there's hope. Everything has a trade-off. That's a fundamental rule of biology and economics, and it's hidden from us as patients in the NHS. The NHS is not free. And we think it's free, but it's not. Even if you're not a taxpayer, you're being denied something as a consequence of the money being paid for you in the NHS. So maybe your life would be better if you got the more support with parenting, or your local environment was changed in some way. That trade-off is not discussed. That's what we need to do. You did some interesting work in terms of where would people choose to have their tax sort of set. That's what I think we need to do with health as well.
Yeah, I've thought about personal health budgets. It's really complicated. But I wonder if we trusted people more, they might be prepared to engage in this subject. I know I had an orthopedic surgeon when I had a problem with my knee, and he said, well, I could operate, but actually I think physio will do the job. And I was thinking, well, I'm entitled to my operation. But I'm so glad I took his advice, because physio did do the job, and it's a lot less time off work. I had another surgeon who said, you've got this problem, maybe you can live with it. and we had a discussion about whether I wanted the treatment or not. And when I had that sense of autonomy, I can imagine a situation in which I might say, actually, you know what, it's not causing me that much difficulty, I don't need the disruption, I don't need to be in the queue, there's plenty of people who need it more than me. I don't know, I think involving the patient in the choices is really good. I probably am pessimistic, like you are, actually, about whether it will happen more. We've got a few minutes. Yes, sir, do you want to ask us the question?
Yeah, a real quick comment and question is, there is as has been mentioned, a class and possibly an ethnicity element in health. I know in my neighbourhood, working class kids eat huge amounts of fried chicken. That's what they eat. And that's going to be a cost. There's also a class element in that among some working class people, the NHS is sort of a way of evening up things. So it's a way that one can get one's rights. So it's very complicated. And so I really think we have to start looking as a society at the implications of, for instance, considering doing something about children's diet. In other words, closing down fried chicken joints. Now, either by consent or not, but yeah, because something like that costs, and we have to, it's very, very difficult, but we need to talk about these things.
Yeah, no, I completely agree. I mean, the idea that we are autonomous, rational agents is just complete rubbish. We're so influenced by our immediate surroundings and then the surroundings outside of that. So if we're really going to make an impact, we need to think environmental. So the Genome Initiative has been amazing in this country, a massive success story. I would like us to have the same sort of vision, but rather than genome, it's behaviourome and environmentome, and how we can then modify that to have an impact on people's lives.
And just on the chicken example, let me give you a personal reflection. 18 months ago, I weighed 26 stone. I was completely unable to manage my intake because I ate far too much fried chicken and far too much fried everything, actually. And it took an enormous effort to change things, not helped by the environment and walking past all of this stuff. So I am sympathetic to changing diets. I'm also acutely aware that it's not just about things like diabetes, but my musculoskeletal system was affected by being very fat. That would have inevitably led to probably 4 joint replacements in my lifetime, which would have been much shorter than otherwise. Tom Watson's book saved my life. So I think there's a lot to be said. Now the question is how we do it. Banning junk food, look, it would make life a lot easier, wouldn't it?
Well, it wouldn't happen because, black market junk food.
Black market junk food, there's a thought. And yes, sir, do you want to ask us a question? And this might be our last one, I think.
Paul Watts, the National Innovation Centre for Data. One of the common themes in many of the sessions I've attended has been the complaint that Britain is too centralised. And we heard that in Stephen Smith's video message to us. But if he was here, I would want to ask him, well, what would a decentralised health service look like and why would that give better outcomes? So I was wondering if Paul had a view on that.
Yeah, I think it's sort of concentric. This is you could say for government in general, it's having concentric rings of organisation with the right links between them, and in general devolving as much down to the local. And particularly for complex systems, you can't predict how things are going to work unless you sort of do the experiment, and you've got a small collection of actors. And the Dunbar number, I don't know if you're familiar with this, it's proposed by an Oxford anthropologist. Our brains have evolved to handle about 100, 150 relationships. That's the optimal size for a unit to work. And it just so happens that's the same size as something called the primary care network, which has evolved over the last 5 or so years, which are several GP practices working together for one locality. I'm a massive fan of that, because then you can have very sort of local population effort. But what I would bring into them is not just the clinicians, but also the local bobby, head teacher, the faith leaders, the local people to sort of think in a coordinated fashion. That's the level I'd be controlling the thing. Now, sure, you need quality controls at a higher level. Some stuff's got to be specialist. But to really make an impact, I'd go PCN level.
Thank you.
Thank you. Oh, I've got 2 minutes, so I've got time for one more question, if anybody would like to ask one of Paul. Yes.
So I think you mentioned before that it would be great to shift more to preventative healthcare. How do we make that cultural and financial shift? Obviously, it's presumably going to cost more money to put more money into preventative health when you've also got to do the treatment side. But I think it feels at the moment we work in obesity policy. A lot of it is treatment focused, and how do we make that cultural shift and financial shift?
So it's a timing problem. That you put in your money and the effort, and then you don't see a return on your investment for years, usually outside of the election cycle. And also the people that are putting in the change, they'll say, well, it's the NHS who's benefiting rather than the local authority. That's why I think you need more innovative the ways in which funding can come back and it can be rewarded. We've got the most innovative financial centre in the world in the City of London. And as I say, we've got now a Chancellor who used, Secretary of State who used to be a Chancellor, and we've got big data. So that's where I think otherwise all of these efforts are not going to work.
Thank you, Paul. I think that last question is absolutely fascinating, because when you said it, being someone who advises a whole range of private sector clients, the first thing I heard when you asked that is, this is a maturity mismatch problem. Short-term cost, long-term benefit. We should go and talk to a bank or a pension about that question. And I just wonder, and then that's basically the answer you gave. Who knew that we should go and consult bankers to solve obesity crises? But maybe that is the answer.
Yeah, and that's why I sort of made a point of those breakthroughs in that gene therapy and the Alzheimer drug, because of the very long-term returns, high upfront costs, complexity. That's going to force. It's financial innovation we need.
Well, on that note, bankers could be the answer to saving the NHS. I'll wrap up and just to say thank you very much to our video contributors and to Dr. Paul Goldsmith. Thank you.